A sprained ankle is one of the most common injuries caused by the participation in sports. It is highly common in rugby due to the high amount of force applied to the ankles. The injury is a soft tissue injury whereby the damage of ligaments around the ankle. The ligaments that can be damaged are the anterior talofibular ligament, the calcanthalofibular ligament, and the posterior talofibular ligament. Ligaments are bands of tissues around the bones that hold the bones in place. As well as damage to ligaments, the capsule that surrounds the ankle joint can also be damaged. The damage causes bleeding within the tissues, which produces a swollen ankle that can be extremely painful. This injury can be caused by a roll of the ankle towards the lateral side, past the boundary of movement, either by an unstable step in rugby, sidestepping, or complications when tackled. To assess the injured area, the toe taps method is used. The first step, talk, which is talking to the injured athlete to try and understand all the information of the injury. Some questions include what happened, where the location of pain is, and how severe. The second step, observe, means to look at the injured area to see first signs of swelling or deformities. The easiest way to assess through observation is to compare both sides of the body, for example, comparing both ankles for differences. The next step, touch, includes gently feeling of the area to feel any sort of deformity or swelling and try to pinpoint the exact location of the injury. An assessor can start either from one area of the leg, either above or below the injured area, and work their way along until pain is felt. The next step is active movement, which involves the player to perform a range of joint movements such as flexion, extension, and rotation. If these can be done without pain, then further assessment can proceed. Passive movement involves the assessor physically mobilizing the joint through flexion, extension, and rotation movements, using a range of movements aimed at identifying the painful areas and any instability in the joint. Finally, a skills test can be asked of the player whereby they perform a skill that is required during the game. For example, a sidestep. If the player is able to perform the satisfaction of the assessor, then the player can return to the game. If the player at any stage of the toe taps assessment finds there to be an exceedance in the amount of pain bearable, then the assessment must stop and medical treatment must begin. This is in the form of the RASA procedure. The first step is rest. First thing to do is stop and immobilize the injured area. If you have injured your ankle within a rugby game, sitting on the sidelines is the first step to recovery. Resting and staying still will limit the ability to injure the ankle further. The rest and discontinuation of playing ensures that the inflammatory response is not stimulated and doesn't begin. The next step is to ice. To reduce the swelling and pain, applying ice for 20 minutes for 3 to 5 times per day, at least 1.5 hours rest between applications. Keep the ice treatment going for up to 72 hours to provide relief from pain and swelling. Using ice cubes in a wet towel or a bag or even frozen vegetables will work. The next step is compression. Wrap a bandage around the injury plus above and below the injury site to provide good compression. The bandage should be firm but not too tight that it can interrupt blood flow. The bandage will help contain the swelling and demobilize the ankle to help limit the possibility to re-injure the area. The next step is to perform elevation. In seeing that the injury is in the lower leg within the ankle, the injured area must be elevated above the hip. When sitting, use another chair to rest your leg, and when laying in a bed, place a pillow under your leg. This in turn will allow for the decrease in swelling as blood flow to the injured area is restricted. It will also remove fluid as a result of inflammation by the use of gravity. Finally, referral. Depending on the severity of the ankle sprain, you may need to seek medical advice for an assessment of the potential damaging effects of the injury. A scan may be required to decide on the treatment. A medical professional can then prepare an injury management plan and a plan for the recovery and rehabilitation. The rehabilitation process begins after the initial RISA treatment for the ankle sprain injury has been applied. Graduated exercise is an important part of the rehabilitation process for a sprained ankle, which involves stretching, conditioning, and recovering total body fitness. As the injured ankle is healing, scar tissue will start to form, and it is important that the injured ankle is mobilized to cope with the stress placed on the joints. Scar tissue result in the loss of flexibility in the joint. Progressive mobilization may provide a slight degree of flexibility back to the athlete's sprained ankle, but it is through correctly completing stretches for muscles around the ankle that will increase circulation, reduce muscular tension, lengthen the muscles and tendons, and overall increase the range of motion. Gentle and light static stretches and P&F stretches are the safest and most effective methods to recovering and improving range of motion at this stage of the rehabilitation. These should be performed when swelling and pain is reduced, usually at a minimum of at least 3 days subsequent to the injury. Exercises should begin at a low level of intensity where there is limited stress on the ankle. Exercise should utilize the principle of the progressive overload. Some exercises include seated dorsiflexion and plantarflexion. These are beneficial as there is no added stress onto the ankle while it increases mobility. The intensity of the exercise can later be increased by the use of a band to increase the amount of resistance placed onto the ankle. This movement increases blood flow, which controls the onset of the inflammatory response. Once the healing process has begun and the pain has limited, movements such as eversion and inversion can be performed, which places a greater stress onto the damaged ligaments. After the muscles and ligaments within the ankle are at a level where there wouldn't be any risk of re-injury, then muscular power, speed, and endurance can be redeveloped. Since the athlete hasn't been exercising for some time, the reversibility effect has taken place. By redeveloping total body fitness, it allows for the preservation of the body's fitness as much as possible after the ankle sprain occurs. Although rehabilitation and recovery of the ankle is most important, it is important that the athlete tries to maintain fitness levels and aims to limit loss of flexibility, strength, and endurance. Methods to do this can involve activities that require impact to put on the joints, such as jogging. So methods such as swimming, cycling, slow walking, and upper body weight training are preferred. Finally, the use of heat and cold. Cold is used in the immediate treatment of the injury and for the first 72 hours to prevent swelling and to treat the internal bleeding. After the first 72 hours, applying heat can be extremely beneficial due to the result of an increased blood flow and to help remove waste products from the injured ankle. It will also provide fresh blood to the ankle, which will improve the rehabilitation process and aid the process of removing scar tissue and to rebuild and reconstruct damaged tissues. Heat can be administered through heat packs or hydrotherapy. There are indicators for the readiness of when to return to play. Before an athlete with an ankle sprain is ready to return to play, they must complete a sport-specific test set by their coach and medical staff. Guidelines they must fulfill include a pain-free range of motion of the ankle with full flexibility and movement with absolute minimal or no discomfort. They must also be pain-free, which is where there is no pain without the use of pain relievers. Elasticity, so the new tissue that has been stretched promoting lengthways elasticity and resultant flexibility. They also have to rebuild strength where the new tissue is strong and able to support the body in stressful movements. Mobility, the athlete has gained full movement, particular in terms of agility. And finally, balance, the injured person is able to balance his or her body on the injured limb until the function is achieved. The rehabilitation process is not complete. There are also psychological readiness factors that have to be considered before a player returns to play. The longer that an athlete is away from the training and competing in their sport, the more likely they are to have lost confidence in their ability to return to the game and get back to the top of their mental and physical capabilities when performing. It is during this time that a coach could provide assistance from a sports psychologist to the athlete to identify the aspects and areas that the athlete believes they have lost confidence in and to work on them. An example in rugby is if a player has a sprain on their ankle, they are less likely to want to sidestep or put weight onto the ankle, which can result in the loss of performance, as the athlete won't use the ankle to its full ability. If there is an overuse of the uninjured ankle, then this could possibly result in an injury to the ankle from too much pressure placed on it. During the rehabilitation process, it is key that the monitoring process of the pre and post state of an athlete is observed. An athlete's progress, both physically and mentally, during the rehabilitation period should be closely and continually monitored by a coach or medical staff when the athlete wants to or has returned to play. The athlete's progress should be monitored at every training session, and they should be put through sport-specific tests or movements to ensure that the athlete is prepared to return to competition. The coach may also monitor the athlete's process and their psychological state through the discussion and interviews with them. Through visual observations and ongoing tests, the coach is able to make a comparison between the athlete's pre-injury performance test and the current status of their set test and decides whether they're ready to return to play. Examples of a skills test could be if the sprained ankle has completely recovered, it is put it is put to the athlete through some agility tests, such as weaving in and out of poles, running around cones, which involve the athlete's sudden change in direction, and running and jumping. These tests could be applied to rugby to see if they can change direction suddenly, capable of sudden bursts of speed, and jumping to catch. Once results of the post-injury state outperform or are similar to the pre-injury state, this could be an indicator that they are ready to return to play. Pressures of the return to play. Often, and particularly in elite levels of rugby, the services of talented players are required before injuries have been fully healed. Some players may have injuries heavily strapped, while others are given injections to prevent pain from pressure or impact of the injured area. Many coaches see players as commodities. They are bound by contracts who need to be on the field to play to gain full value for cost. Irrespective of financial binds, it is unwise and dangerous to insist on or pressure players to resume competitive sport before injuries have fully healed. This results in some players taking painkillers to return to play before the full healing of the injury. Some athletes use prescription painkillers to mask the pain that would normally be present during the activity. Pain is the body's response to tissue damage. It tells us that what is happening is causing harm and should be stopped. Pain-killing injections desensitize the injured tissue and set an environment for further damage without the athlete being aware of what's happening. This prolongs the healing process. If further rupturing occurs, permanent mutilation of fibers will occur. Choices about the use of painkillers affect elite sports people more and more than everyday athletes. The choice to use painkillers results in a consultation between a player and coach, but ultimately the player's future is what is at risk.